of ankle dorsiflexion or passive ankle extension and subtalar abduction as part of the treatment protocol indications for certain types of treatment. And when we look at the subtalar joint, it's the same idea. I look at the foot from the top, and then let's just see. There, do the Ponseti maneuver, supinate and abduct, thumb on the talar head. I take the foot as far as it will go. This is an older child, but you can see here, that's it. Now the foot, the subtalar joint is as abducted as it's going to be. And then in my mind's eye, I identify the patella, the line of the femur, the talar head, the line of the sacrometatarsal, and I estimate this angle here. And we don't measure it to the nearest degree, but if you can get it down to the nearest 10 degrees or so, that's pretty good, because then you can get an idea of how much adduction or abduction is there in the subtalar joint. There isn't a standardized way of doing this, unfortunately. This is something we're working on right now, a standardized way of determining these angles. So it's something that needs to be done. So that's measuring angles, but what has been validated and is being used worldwide, and this is why we developed it, because we needed to understand exactly what was happening in the foot, not just by angles, but by actual deformities in the hindfoot and the midfoot. The Pirani score is 6 signs, and each of these signs, they change as the clubfoot corrects with Ponseti treatment. There are 3 signs in the hindfoot, 3 signs in the midfoot. Each sign is scored 0.5 of 1, and the scoring is performed improvements or relapse, and it guides treatment on that particular visit. And here's the example of a curved lateral border, which is either 0, it's almost straight or straight, half, which is a curve, and then a 1, which is really very curved. And we've got I have some more pictures that, so this you can see, the Pirani score actually becomes the equivalent of the blood sugar of the clubfoot. Measure it every time, and it tells you what to do. And so, for example, if you look at the Pirani score graph over time, here's the scores, here's the weeks of treatment, and you can see this is the treatment that's applied. And here's a typical clubfoot that starts out at 6, the total score, and it comes down every week. And you can see you apply casts when the midfoot score is still high, but when the midfoot score is low and the hindfoot score is still high, that's the indication, do the tenotomy. You apply the last cast, and then the clubfoot, the Pirani score remains down during the phase of bracing. And so if we draw this graph, we can actually understand what's happening. And we'll come back to this graph and how it can be useful in due course later on. Right. So let's look at these individual signs in more detail. The posterior crease, look at the foot from behind, look at this crease here. And if you look at your thenar eminence, or hypothenar eminence, you'll see multiple fine creases, and that's the equivalent of a 0. If you look at the IP joint, the volar aspect of the IP joint of your thumb, and you extend the thumb fully, you'll see a single deep crease, but it'll be very smooth. Whereas if you flex the IP joint of your thumb, that crease becomes much deeper. And so that's the difference between a 0.5 and a 1. A shallow, non-indenting crease compared to a single indenting crease. That's the posterior crease. The empty heel sign, we take the foot, we look at it from one side or the other. With one hand, you extend the ankle as far as you can go. And with the other hand, other finger, you press on the corner of the heel. And what you're trying to do is you're trying to feel for the calcaneal tuberosity.
I request
if somebody's on the phone, if they can mute themselves, that's great. So if when you, with your finger number 2, if you feel the calcaneal tuberosity right there, your finger is on the tuberosity, that's a 0. And the equivalent of that is when you touch your forehead. When you touch your forehead, your finger is right on the skull, and that's what it feels like. If, however, the tuberosity is felt only with deep palpation, okay, and then that's a half. And you can convince yourself of these by touching your nose. If you touch your nose from the top, from the front, and you push with your finger, you will touch the nasal bone only after the finger has moved in. Whereas if this is where you can't feel the tuberosity at all, and the way I demonstrate this is if you touch your thenar eminence of one hand with the index finger of the opposite hand, and you try and feel for the first metacarpal, you won't be able to feel it because the thenar muscles are in the way. That's a 0, half, and 1 for anti-heel sign. And then the third sign of the hindfoot score is rigid equinus, which is where if you extend the ankle, if the ankle goes above neutral, it's a 0. If it only reaches neutral, it's a half. If it goes below neutral, it's a 1. And then the midfoot score, there are 3 signs of the midfoot. If the lateral border is straight, it's a 0. If it's gently curved, it's a half. And then quite often you see what we call a boomerang curve, which looks like a boomerang, and that's a 1. And you can see actually that these pictures are also very good for looking at the midfoot score signs of a medial crease. This is again like a 0, which is like the thenar eminence. This is the IP joint of the thumb, but with the IP joint extended, it's a shallow single crease. And if you flex the IP joint of your thumb, you get a deep crease, and that's a 1. And then lastly, the talar head sign. And what we're trying to do here is to try and understand how well does the navicular reduce over the talar head when you abduct the foot. So you put your thumb over the talar head, and then you abduct the foot. And with your thumb, you're feeling for the navicular. Now, if the navicular slides in between your thumb and the talar head, that's a 0. You can't feel the talar head. If the navicular reduces partially and the talar head and the navicular are both palpable, that's a half. And if the navicular does not reduce, and even with the foot fully abducted, or as abducted as you can make it at the particular day of the visit, if the navicular does not reduce and you can only still feel the talar head, then it's a 1. So these are the signs that I thought I'd go into in a little bit more detail so that it's clear. And then we've tested these, we validated it with inter-observer reliability with very good kappa scores for the 3 scores. We've also validated against MRI, but I won't go into that right now. Here's an example, pre-treatment, curved lateral border 1, medial crease 1, lateral head of talar sign 1, midfoot score 3, posterior crease sign 1, empty heel sign 1, rigid equinus 1, hindfoot score 3, total score 6. This is pre-treatment. And then this is when the foot is more corrected. The curved lateral border is 0, medial crease is 0, lateral head of the talus is 0. So midfoot score is 0.5, hindfoot score is still 2. We can see here there's still not sufficient ankle dorsiflexion. So we do the tenotomy, and immediately there's an improvement in the posterior crease. So you can see how the Pirani score actually shows how the foot is correcting. And here is an example of how the Pirani score graph can highlight problems. Here we see a cast that was put on that was ineffective. This cast was put in a good correction. The foot was fully, there's improvement, but this cast shows where it looks more like the first cast rather than the more better cast. And so the Pirani score went up. So this would be an example of a Pirani score, a graph that shows an ineffective third cast. Here you see the early treatment is excellent, but here you can see the child isn't wearing the brace and there's relapse happening. So this is an example of relapse. Here you see a Pirani score graph during the syndromic response, although we don't usually use the Pirani score for syndromic club feet, so probably not a good idea to do this, but this is just to give you an example. And then this is the usual response, as I mentioned before. So that's, and now I'm starting the talk for next time. Shall we entertain some questions?
Yes, there is a very good question by Dr. Khatri, and that was like how do you evaluate the Pirani score? By after manipulating or correcting the deformity, or without correcting the deformity?
So the Pirani score is, think of it as what you do every time you look at the foot at every clinic visit. So before, at the first visit, you can score the foot. And this would be an example of the first visit before you put the cast on. And then you put the cast on. And if it's a good cast, then the next week when they come back, you take this cast off and you score the foot again, and you should see an improvement, right? And then so you always, it's a bit, the equivalent is like measuring the blood sugar. When the patient with diabetes comes in, they have the blood sugar measured, and then they determine what the treatment should be. So you can see in this situation, normally speaking, you apply casts every week until the midfoot is fully corrected. And only when the midfoot is fully corrected and the equinus is persisting, then you do the tenotomy. So the decision as to what to do will depend on the Pirani score. Does that answer the question?
Yes. Yeah. The
Right.
second question, which is like when we of the foot, because that is going to tell us how many plasters we are going to require for correction. So do we have any score or any method by which we can look at the rigidity or the stiffness of the foot?
So yes, and thank you for that very good question. What we're actually referring to is the slope of this graph.
Exactly, exactly.
Right.
But that is when the treatment is going on, we get the slope. But
yes,
when we are starting the treatment,
there is no correlation. You see, the stiffness, or the so-called stiffness, it actually, if you take the same foot and you give it to one doctor or you give it to another doctor, they may have differences in the way, in the number of casts that are applied. So the so-called stiffness is both a function of the foot as well as the doctor. And because the thing is, we come back to this idea of an ineffective cast. That one, okay? So is this a fault of the foot, or is this a fault of the doctor? So it's true that the Pirani score does not give you a prognosis. It's also true the Pirani score allows you to understand the slope of what's going on, providing it's the one doctor who's always putting on a very, very effective cast. But one of the issues we don't have a good handle on is how do you incorporate this kind of situation where a cast is put on by a junior. I mean, I ask all of you, how many of you put on your own casts? And if you leave it to somebody else to put on the cast, how do you know that the cast that was put on is effective? And the principle, we understand the principle of making sure that you have obtained and maintained satisfactory reduction in a both bones forearm fracture when you put a cast on a both bones forearm fracture because you take an x-ray afterwards. But how many people actually look at the cast that was applied and compare the cast that was applied to the passive subtalar and dorsiflex extension ankles that were obtained? So this is an interesting issue that is raised, and I think it points to the fact that there's still something we need to do so that we get a standardized way of looking at the cast afterwards to make sure that it's an effective cast.
Okay. Then there is a question by Devendra. What are your views on Bijlani corrective cast in walking children? Are they advisable or to be avoided?
So maybe we can talk about that question next time. Let's save that question because that's about treatment. And we need to talk about treatment before we can talk about the answer to that very interesting question, because it is a problem. I understand it's a problem.
The next question is also, I am sure that you are going to say the same thing that we are going to take next time. What is the percentage of children requiring tenotomy after applying cast? So I think we are going to discuss that next time.
It's a good idea because we let's save that question, because that question really asks what is the indication for a tenotomy. Okay, and when we look at Dr. Ponseti's book, he answers that question very clearly. But I'm going to save that answer for next time.
Then there is a very difficult question by Professor Anil Agrawal. What is the pathology of cock-up toes? Why are other toes not affected in the same setting? Like, so great toe is extended, why the other toes are not?
In a complex clubfoot?
Yes.
Or yeah. So what happened in a complex clubfoot, and this was actually explained to me by Fred Dietz, again, about 20 years ago. He passed away, unfortunately. He was Dr. Ponseti's right-hand man for so many years. And what he indicated to me is that what happens in a complex clubfoot is that if the cast is not applied properly, then the foot will move in the cast. The foot will move in the cast, and the foot generally will, the cast will tend to slip off, so that the heel will not be in the part of the heel cup. It'll go higher up and it'll become flat, a flat heel. But what happens then is that the midfoot tends to plantarflex. You create a plantaris, or you create cavus in the midfoot. And when you create cavus in the midfoot, it relaxes the plantar fascia. And when you relax the plantar fascia by the windlass mechanism, the extensor hallucis longus will cause the toe to cock up. That was the explanation that I received. And I understand that. And that's why when you push up on the talar head, not the talar head, the first metatarsal head, during your modified Ponseti casting, that's what allows the cock-up toe to come down, because you're correcting the cavus. Does that answer your question, Dr. Agarwal?
I think yes, because we actually don't know, but this is what you said is the hypothesis. And I think at this stage, yeah, your hypothesis is absolutely explain the pathology.
Yeah, that's not, you know, because if we don't see a cock-up toe if the cast hasn't slipped. But let's save that question for next time too.
Okay, then there is a question from Dr. Noor Wahab. He's from Pakistan. He's an orthopedic resident. And the question is, sir, every scoring system is for some purpose. So the question is, what for Ponseti score is true the spirit? Is it a functional scoring system, or it is for the prognosis?
Well, that's why I come to issue of classification and assessment, and I separate them. Okay, we understand that for diabetes, the prognosis does not depend on the blood sugar. The long-term prognosis depends on the type of diabetes. The prognosis of type 1 diabetes, what's going to happen to you in your life, is different from what happens in type 2 diabetes or gestational diabetes. It's the same thing for clubfoot. So the long-term prognosis depends on, let's just see. Let's go back to this. Long-term prognosis. What will happen to your child when they are grown up? It depends on what is the diagnosis. The prognosis for syndromic club feet is very different from the prognosis of untreated club feet. It also, the prognosis also depends on how satisfactory was the treatment that was applied. We know from Cooper and Dietz's 1995 paper that at a minimum 25 years outcome, untreated non-walking club feet, treated properly with the Ponseti method, have a 75% chance of having a good or excellent outcome, which is this. However, Matt Dobbs' 2006 paper, where he looked at 25-year outcomes after surgery, invasive surgery, they have exactly the opposite. They have a 75% chance of being totally disabled by the time they're 25. So the long-term prognosis depends on what is the type of club feet and how well was the treatment applied. The purpose of the Pirani score is just to help those people who are treating club feet know what to do on a particular day and when they're in the clinic. So in other words, this, what should I do today in the clinic? Should I do a tenotomy, or should I put a cast on, or should I brace, or what should I do? What's happening? That's the reason why we do the Pirani score. So it's not one or the other, it's both. Did I answer the question, Dhiren?
Yes, yeah. Then there is a question from Dr. Akash, and the same question was from Dr. Wahab also. Till what age do you usually apply Pirani scoring?
So the Pirani score has been validated. What we did with the Pirani score is we looked at this here. We validated it only between 0 and 13 months of age. So if you ask me, have you tested the Pirani score on walking children? The answer is no. Can you use it on walking children? The answer is I don't know. Do people use it on walking children? The answer is yes. But should they use it on walking children? I don't know the answer to that. I would use it for the vast majority of club feet that have come to you in infancy, because we have tested it there. We know what it means because we have looked at 29 feet, which we did MRIs on, and we did Pirani scores and MRI, and we could tell that if the Pirani score was high, the MRI showed high deformity. If the Pirani score was low, the MRI showed little deformity. So we were able to validate it. But we haven't done that. And what the Ponseti International Association guidelines talk about, the 2015 guidelines, and I'll come to this another time, is measurement of angles. And unfortunately, there is no standardized way of measuring angles. So that's why I've made these videos to show how I measure them, to try and get them. But you can see, if we go back to this algorithm, it talks about angles. So for example, you'll see here 15 degrees of dorsiflexion, 0 degrees dorsiflexion or ankle extension, et cetera, et cetera. So for complex club feet, the treatment is based on angles, et cetera. For idiopathic club feet, you can use the Pirani scores guidelines.
Okay. Then there is a question from Dr. Bose. Is there any role of tenotomy of tibialis posterior tendon if midfoot correction is not fully corrected?
So the tibialis posterior tendon, there was a time I used to operate on club feet, posterior medial release, Cincinnati incisions, et cetera, and not infrequently, or maybe once or twice, I couldn't find a tibialis posterior tendon. There was no tibialis posterior tendon. I believe the tibialis posterior tendon is probably a slightly innocent bystander, because the deformity, we know the deforming force is the tibialis anterior, because it supinates the foot, and we know the deforming force is the posterior medial rotating fibrosis, and we know the deforming force is in the gastrocsoleus complex. There was a doctor in Zambia, and I forget his name, but he used to do an operation where he would do a tenotomy of the tibialis posterior as part of the treatment. But I've never found anybody else who does that. So I don't know if there is a role. And why would we want to do that? Because if the Ponseti treatment is properly applied, at least in the context of idiopathic non-walking club feet, then there's hardly ever the need for a posterior medial release or any form of invasive surgery. But in other types of club feet, say a child who's much older, or possibly in some types of syndromic club feet, there may be, but this is a question that needs to be explored with a study rather than just my opinion. My opinion is there isn't a place for it.
Then there is a question from Dr. Akash Ghosh. For assessing medial crease or posterior crease when a previous cast is removed, would you assess it in the resting position of the foot or in a corrected position? Means like after applying the stretching.
Yeah, so let's just go to this picture. So what you should do is you should gently push the foot, okay, to the point of maximum correction, and then assess it. Because otherwise, you're not assessing the soft tissues in a position where they can actually show how much correction has occurred. So these pictures aren't exactly perfect. There should be a picture that shows the foot being pushed into like this. So this, you would do this, and then you would look at the posterior crease. And the same for the medial crease.
Yeah, then there is another question, which probably you will say that we will cover next time. We know follow-up should be up to 4 years. If it relapses after 4 years, then how should we proceed? I think we are going to cover relapse part in the subsequent part.
Yeah, that's also another area for concern, because Dr. Ponseti, his studies showed that relapse rate was 90% at age 1 if you didn't wear the brace, and about 50% at age 2 if you didn't wear the brace. That's why he increased the rate, the age to which you should wear a brace till age 4 in his later writings, because the relapse rate was then down by about 10%. So for every 10 children who wear a brace at age 4, 9 don't really need it. Only 1 needs it. But can you make 10 children wear a brace where only 1 needs it? But we don't know how to determine the 1 that needs it compared to the 9 that don't. We don't know if there are any clinical signs, something that they'll tell us, something that we need to explore. So he then suggested, and PIA recommends, going on with bracing until the parents and the child will no longer tolerate it. But still, there is still a relapse rate, and I've seen it myself, at age 8 or 9 or 10 or 11. And so follow-up needs to continue. How long it needs to continue, it depends on what your capacity is and how it should be treated. The treatment should still follow the same principles, because the treatment does work. But maybe that's a question for next time also, and also maybe for your lecture on relapse, which I think you have planned.
Okay. Shafique, just like in your long career of 30 years, how you see Ponseti method? Because as like we discussed earlier, I know that when you started your practice, you are considering to be a surgeon who is expert of Ponseti at the clubfoot surgery.
Correct.
But at that point, the Ponseti technique came. So how do you see this in the span of 30 years? What are the challenges still not solved? And what the next generation, means the young pedipods, should look for to answer those questions?
So the clubfoot treatment has undergone a revolution in the last 30 years. Revolution, not evolution, but revolution. Evolution is where things change slowly from slightly bit over generations. You know, the Ponseti treatment for clubfoot is a bit like the introduction of intramedullary nailing for long bone fractures, or total hip replacement for osteoarthritis of the hip, or arthroscopy for sports injuries of the knee, etc. These are revolutions. Ponseti treatment is in itself a revolution. And but just like intramedullary nailing of the femur, it has to be done properly. And just like you classify fractures of the femur in different ways, and each of those little fracture differences have a different way of treatment, just like you look at knee ligament injuries in different ways, and they may all be treated arthroscopically, but they all have the nuances. Clubfoot is also in that situation. That's why I show this slide, because unless one appreciates that there are these different types of club feet, one may be tempted to treat an atypical clubfoot like an untreated non-walking clubfoot, and it won't happen right. And indeed, the major issue I see is that there are errors. The Ponseti treatment is there are still significant amount of errors that are seen. There's one study by Nancy Miller in 2016, and what she did was it was a two institution study in North America, in the United States, two children's hospitals. One children's hospital, they looked at their club feet and they treated their club feet by what was called strict Ponseti. They adhered to the principles of Dr. Ponseti, and their surgical rate was 2%, invasive surgery. Another institution where they used what they call loose Ponseti, i.e. they didn't do things exactly the way Dr. Ponseti prescribed, their surgical rate of joint invasive surgeries was almost 50%. Now, if we see that in the United States, right, where there are plenty of doctors, but these are decision errors. These are clinical decision errors by the doctor. Why did the doctor decide to do some things when they didn't know if it was going to be right, when what Dr. Ponseti has said works? So the area we now need to explore is a fuller and more complete understanding of how each of these different types of club feet should be treated, and a concerted effort to make that treatment available in all low and middle income countries, because still many children present late for treatment, and some don't get any treatment at all. And then how is it that we are going to be able to figure out what are the differences between all these different types of club feet and what needs to be done for them? And whereas orthopedic surgeons have a great tool with x-rays to look at what's actually happening to the individual bones or the fracture fragments, we don't have that in club feet. I was very fortunate that we were able to use MRI to understand what's going on. But imagine if we had the ability to understand exactly what was happening to the pathology of the clubfoot that I demonstrated by some form of easy investigation to know what's going on. It would help us understand. So we're a bit blinded, and still we don't actually have a proper way of looking at it. So these are some of the challenges I see for the future generations. And it's not a small problem. If we think about the number of children that are born in India, number of children that are born on the planet each year, 200,000 children born on the planet each year with clubfoot, and it's not going to go away. Right? We don't know anything to prevent a clubfoot. We just have to manage it, which means early identification, which means early treatment and proper treatment. And it's a problem because the treatment has to go on for at least 4 years, perhaps longer. How do we make the treatment better? So that's how I see the landscape of what has happened in the past with clubfoot treatment and what needs to be thought about and looked at for the future.
There are two questions. Both
Yes.
The questions are from Bangladesh, but both are related with the post-correction maintenance. So I think that it's better that we take those questions next time, once
Yes.
we have corrected the bracing, and then we are talking about the management, how to deal with the children. So we will take both the questions, Kaiser's question and Dr. Mohammad Ghulam question next time.
Okay.
So with that, Shafique, I really thank you for your wonderful explanation about the basic concepts of Ponseti technique, And I'm sure that the next session is going to be equally more interesting. The reason is because it's going to be more important for everyone. That's the management. So with that, I thank everyone for joining the session, and thank Shafique and OrthoTV for making this channel live stream so that everyone can view later on also. So thank you once again, and bye-bye. Shafique, anything what would you like to say?
No, just I'm pleased to be able to answer questions and to encourage those interested in the clubfoot deformity to think more about what needs to be done, because there's more that needs to be done, and the more discussion and more collaboration we have to look at the questions of the future, there's a great opportunity to make things better for children. Remember that a child born with a clubfoot was going to rely on that foot for decades. And untreated club feet or poorly treated club feet, the doctor will only be around for 20 or 30 years. The child's going to be around for 60 or 70, 80 years. So we have to think what's going to be good for that child years from now, not what's good for the doctor.
Yeah, that's very important. Thank you. Thank you.
Okay. Thank you.
Bye.
All right. Thank you. Bye-bye.